The next bill before us is House File 2143. Representative Romani-Hiltzy, please move your bill and introduce it.
Thank you so much, Chair Noor and Chair Schumacher. I do have an amendment.
So Representative Romani-Hiltzy moves House File 2143 be laid over for possible inclusion, and you have an A2 amendment. So members, we have A2 amendment before us. All those in favor, please say aye. Aye. Opposed? The A2 amendment is adopted. To your bill as amended.
Thank you so much, Chair Noor and Chair Schumacher and honorable members of this committee for the opportunity to present House File 2143, a bill rooted in lived experiences of Minnesotans across this state. This bill is about strengthening our mental health system with compassion, common sense, and equity. It is designed to remove barriers that prevent people, especially those in rural, underserved, and under-resourced communities from accessing the care that they need to stay well. In Section 1 of this bill, it allows the continued use of telephonic care, a critical lifeline for many Minnesotans with mental health illness, particularly in rural areas where broadband is unavailable. While video telehealth and in-person visits are ideal, we cannot ignore the realities that some of our most vulnerable residents don't have smartphones, laptops, or internet access. Audio-only communication ensures that they can maintain consistent and meaningful contact with their providers. And then if you look at Section 2, it expands access to mental health case management in several important ways. First, it lowers the threshold of eligibility by reducing numbers of required hospitalization from 2 to 1 within the past 12 months. Second, it adds PTSD and trauma-related PTSD to a list of qualifying diagnoses. Third, it extends the eligibility period of people who've been civilly committed to from 3 years to 5. And then finally, it recognizes that continued care management can be preventative. Section 3 increases the reimbursement rates for protected transportation, offering a humane, non-police alternative for transporting individuals with mental health crises. And Section 4, it establishes grants for early episode of bipolar disorder program. And then finally, Section 5, it supports the expansion of first episode psychosis program, recognizing how powerful early intervention can be in changing the trajectory of a young person's life. I would like to turn it over to my expert testifier, who will speak further on the critical need and significance of this bill.
Thank you, Mr. Chairman. Member Sue Abderholden, Executive Director of NAMI Minnesota. I want to highlight a couple of items in the bill that won't be covered by other testifiers. Case management is actually a very low-cost service that can really help people with serious mental illnesses stay connected. Right now, people with PTSD do not qualify for case management. We were contacted by several culturally specific providers who said that in years past, they might have diagnosed someone with borderline personality disorder, but truly it's due to historical and other trauma, and so it really should be PTSD. But if they diagnose someone with PTSD, they won't then qualify for case management. I will say that it's not just having the diagnosis of PTSD. You still have to meet all the other criteria, which includes having a real impact on your day-to-day activities. Also, we wanted to make sure that we look at some other ways, too, to make sure people stay in case management, especially if someone has been committed. Just within the last 3 years often isn't enough. We really need it to be 5 years. And these days, it's not just someone being hospitalized. It can be hard to get hospitalized, right? So why would we say you have to do it twice in a year when once in a year actually would still mean that you might need that particular service? We also often use residential now, and so if someone's been in residential, we think they should also qualify for case management because they would have had an acute episode. And then finally, what we've heard over and over from folks is that they started getting better, they were in recovery, case management was really helping, and then they're like, well, now you're well, you don't need it anymore. But someone actually might need it to stay well. And again, it's a very low-cost service. We do understand this is a cost to the counties, which is why we amended the bill to take some of the other diagnoses out and just focus on trauma, PTSD, and PTSD. Audio-only telehealth has really helped people with mental illnesses. We've seen lower rates of missing appointments because they can actually just hook up by phone. But a lot of people with mental illnesses, serious mental illnesses, frankly, are living on SSI and not much money per month. And so they don't actually have a smartphone, they don't have a computer, they don't have access to the internet. And so the telephone, when you think about therapy, you're talking, right? So it kind of makes sense to make sure that people stay connected. I also wanted to talk about protected transport, which was added to non-emergency medical transportation many years ago as a way to transport people with dignity and frankly at lesser costs than things like EMTs, police, sheriff, things like that. But the rate was set so low that we only have about 2 or 3 vehicles in the state, so we want to take care of that. The amendment included residential staff, when they get training on medications, to also learn about tardive dyskinesia. Tardive dyskinesia can't go back. You can't cure it. And so the important part is to catch it early. And tardive dyskinesia comes from being on psychotropic medications. So we want to make sure that everyone's kind of aware of those symptoms so that we can catch people early and make sure it doesn't actually progress and become worse. There are 3 other programs in the bill, and I know we have testifiers on them, but I just want to mention that 2 of the programs you're going to hear about, first episode of psychosis and early episode of bipolar disorder, makes such a huge difference in people's lives. These are some of the most serious mental illnesses out there. If we can prevent them from becoming disabling, we should. Thank you so much for the opportunity to testify this morning.
Thank you for your testimony. To the next testifier, please come to the testify table, introduce yourself for the record, and proceed with your testimony.
I'll just stay in case there's any questions.
Thank you. Good morning, Mr. Chair and members of the committee. My name is Kate Miley, and I am an adjunct assistant professor in the Department of Psychiatry and Behavioral Sciences at the University of Minnesota Medical School, a clinician in our first episode psychosis and early bipolar disorder programs, and a mental health services researcher. I'm here to support this bill, especially sections 4 and 5, which focus on sustaining early psychosis programs and the innovative yet common sense ways we can expand these programs for bipolar disorder. These are services that are crucial for our community and save lives. This bill aims to support coordinated specialty care programs, also called Navigate, in Minnesota. These are comprehensive teams that work together to help young people with psychosis learn how to manage their symptoms, provide support for families, and help people get back to work and school. This is widely recognized as the gold standard in early intervention, and thanks to DHS funding, we currently have 6 such programs across Minnesota. But despite adding new programs, referrals keep rising, and too many people are waiting, or worse, never have the opportunity to receive life-saving care they need. But our state also needs funding for early bipolar disorder. Similar to psychotic disorders, bipolar disorder usually has a young age of onset and results in high rates of disability and suicide. In fact, it's the 4th leading cause of disability in young people and has the highest suicide risk of any psychiatric disorder in youth. Young people with bipolar disorder have similar treatment needs as those with psychosis, yet can take as long as 6 to 7 years to receive proper treatment. They need comprehensive early intervention, but are left without access to critical programs like Navigate. Because of this, our state recently funded a team of experts at the University of Minnesota to develop an early bipolar disorder program that adapts Navigate for bipolar disorder. The need for such programs is great. Other states are already using our model to expand their psychosis services to young people with bipolar disorder. However, while this funding allowed our team to create an innovative program, it only covered its development, not actually implement it. We recently launched a small pilot of this program, and it's already shown its value, but we were only serving a small fraction of those in need, and sustaining it to provide timely access to care remains a significant challenge without proper funding. Please imagine for a moment what it would be like for a loved one and your family to have your lives turned upside down by extreme symptoms of mania, depression, and psychosis. What would you want their care to look like? Your loved one, perhaps they are currently in college or just starting their first job, might be experiencing a sudden change in their mood, sleeping very little, and are confused by messages they are receiving from voices in their head. They need to be hospitalized, losing their job, or spiraling out of school. Meanwhile, your family's world seems to be falling apart as you navigate a fragmented mental health system to help your loved one get back on track while dealing with a new diagnosis and ongoing symptoms, all while trying to keep up at work or school. Our programs meet people at exactly this place when they and their families have many needs that must be addressed to help them learn about and manage their condition and begin to thrive again. Having a first diagnosis of psychosis or bipolar disorder can be devastating, but it doesn't have to be. Coordinated specialty care programs provide hope and help people truly recover to lead full and meaningful lives. In closing, we know these programs work, and we have the research to back it up. First episode psychosis services have become a cornerstone of Minnesota's mental health infrastructure. We can leverage this infrastructure to deliver bipolar disorder services just the same. Thank you for your time, and I'm happy to answer any questions.
Thank you so much for your testimony. The next person we have is President Larson. Welcome to the committee. Mr. President, please introduce yourself for the record and proceed.
Hello, Chair Knorr, Chair Schumacher, members of the committee. My name is Robert Larson Deuce. I am president of the Lower Sioux Indian community in the state of Minnesota, testifying in that capacity. Lower Sioux Indian community in the state of Minnesota, a sovereign and federally recognized tribe, supports House File 2143 as amended. This bill includes a revision to Minnesota statutes, section 246.462, subdivision 20, for broadening the eligibility for targeted case management and community support services to include complex post-traumatic stress disorder. This would include someone who has post-traumatic stress disorder symptoms that significantly interfere with daily functioning related to intergenerational trauma, racial trauma, or unresolved historical grief. The current eligibility for these critical services does not take into consideration impacts of historical trauma, and therefore individuals with PTSD related to such trauma are not eligible. Targeted case managers play an important role to assess and address significant impacts of health of the people they serve, and this legislative change would ensure they have access to this care. Indigenous people have experienced trauma from war, death, stolen land, broken treaties, suppression of their spiritual beliefs, forcible removal of children from their families, from the tribe and the culture, and systematic racism. Federal Indian law and policy during the removal, reservation system, allotment and assimilation and termination eras are documented painful chapters in U.S. history. Indigenous people have also experienced high rates of out-of-home placement in child welfare proceedings as a result of various state practices and federal policy designed to destroy the Indian family's core and connection to their tribe, including their language and culture. It also stems from federal policy on boarding schools. Despite the First Amendment freedom of religion guarantees, Indigenous people were targeted for punishment when they practiced their religious beliefs. In 1978, in my lifetime, Congress passed the Indian Child Welfare Act and the American Indian Religious Act. Yet intergenerational trauma, racial trauma, and unresolved historical grief continues to affect many of our people to this day. As recently as 2022, the U.S. Department of Interior acknowledged the intergenerational trauma caused by federal boarding school policies. The community's mental health case managers frequently come across intergenerational trauma, racial trauma, or unresolved historical grief as a basis for patient mental health concerns. Since 2023, 43% of adults seeking mental health services in coordination with our mental health case managers were due to these concerns. Your support of this bill would help mental health targeted case managers support Minnesota's medical assistance population on their path toward healing. The community also supports the revision that accommodates continued case management or community support services for adults so they can maintain their recovery. We urge you the committee to support House File 2143. Appreciate your time and your work for the people. Penamudo, thank you.
Thank you so much, Mr. President. Do we have anyone else who wants to testify on this bill? Welcome to the committee. Please introduce yourself for the record and proceed.
Hi, thank you. Good morning, Chair and members of the committee. My name is Jamie Hayes, and I'm the Human Services Director with LeSueur County. I'm also the Behavioral Health Committee Tri-Chair with MACSA, the Minnesota Association of County Social Services Administrators. I want to thank Representative Mamani Hiltzi for bringing forward this legislation and for taking the time to meet with counties in advance of this hearing to talk about our concerns. First of all, counties share the goals reflected in this legislation to expand mental health case management eligibility. We also support the rate increase for protected transport funding and for early episode disorder grants. We strongly believe in the benefits of case management, particularly for those with severe persistent mental illness, or SPMI. We look forward to working with advocates and Representative Mamani Hiltzi to advance that shared goal. As we do that, I'd like to share some high-level concerns that counties have. Counties perform case management services, although in some cases we do contract for that work. Case management services are not funded by the state. Rather, counties pay the non-federal share for the services. Our concern is that an expansion of case management services would put an additional strain already on a stretched workforce and county property taxes. Additionally, this bill proposes to expand the definition of SPMI, not only in case management, but in other mental health services, including adult mental health initiative services. If the legislature chooses to expand the population served by adult mental health initiatives, we would also encourage you to consider a proportional increase in funding for those services. Thank you for the opportunity to provide some insights on how counties think about these issues. We look forward to working with the bill author and advocates to best understand the scope of the proposed expansion, so that we can properly estimate the impact of our staff and our budgets and have an open conversation to ensure that more Minnesotans have access to the mental health case management services. Thank you.
Thank you. Thank you so much for your testimony. Do we have anyone else? Seeing none. Members' discussion. Representative Hicks.
Thank you so much. I love this bill for a variety of reasons, but one of the reasons that I love it is because, and I know you trimmed it down for what would be qualified, but the fact that we limit services when someone is clearly in need of them by a DX code in a file somewhere, when what we're seeing clearly meets all of the other criteria, is something that has frustrated me for decades. Because the truth of the matter is, case management does cost money, but when high-quality case management occurs, we can have case managers support people to access medical assistance and keep their paperwork up to date so they don't get kicked off MA, so the county's not paying for holding at jails because somebody didn't take their medication and had an incident and there wasn't any places at the hospital, because that's happening too. Case management costs money, but when we don't have case management, we have people who struggle with mental health issues and severe persistent mental illness, losing their children into the child welfare system where we're paying for foster care and we're paying for family reunification and we're pulling down all of these other funds, but we didn't have case management up front. When we don't have case management up front, which costs money, we have individuals who are cycling in and out of our hospital system many times on and off of medical assistance, needing to utilize a variety of social support systems because we can't keep them housed. When we don't have case management, all of these other things happen. Case management is an investment on the front end that pays massive dividends on the back end when we can ensure that people who have severe and persistent mental health disorders can remain supported, housed, and moving forward to their best lives, including things like employment, including things like long-term treatment, including things like getting better. People with severe and persistent mental illness recover, but they do not recover if we create a system that only allows them to access the supports to recover when they have hit bottom 3 times in a year or 2 times in a year, or it's illogical. So thank you for this bill. Thank you to our testifiers, and thank you for the advocates that have worked in this space for so long to say, little bit up front, a lot of dividend on the back end.
Any other member discussion? Vice Chair Hill.
Thank you, Chair. Thank you, Representative, and thank you for taking the amendment, adding the amendment onto this. I want to talk about the amendment component around the CPTSD. I want to say whooping to President Larson for making the trip, not only from Greater Minnesota, but also not even a week after surgery. I think that is just a testament to his leadership and standing up for the needs of his community and what they're asking. What President Larson was talking about is real and emotional. Just listening to him explain that in real time brings up the emotions that I think he's trying to talk about. The flip side of that is I stepped out this morning to go, Red Lake Nation is here doing drumming and ceremony to start the day, and that's the healing component of it. And so I really would love this committee to consider when a community comes forward and says that this is what we need to heal, that we respect that and we honor that and we know that that's real. And so I just want to acknowledge that sharing that is hard to do, and sharing that on behalf of our people is honorable. And I'm just really happy to be in this space with you, President Larson, and the work that we're doing for our next generations. We'll be done.
Thank you. To your closing remarks, Representative Mwanya-Hilson.
Thank you so much, Chair Noor and Chair Schumacher and the members of this committee and all of the testifiers. Thank you for your thoughtful engagement in House File 2143. This bill is about meeting people where they are, with care, with dignity, and with urgency. It reflects the realities of Minnesotans navigating our mental health system and offers practical and people-centered solutions. From expanding access to case management to maintaining audio-only telehealth for those in rural and underserved communities, to ensuring that early interventions for serious mental health, House File 2143 is rooted in community voices, and is shaped by collaboration. I also want to acknowledge that there are concerns, particularly around the potential impact of counties. And I want to acknowledge that those concerns are part of an ongoing conversation, and my door is always open. And I remain committed to working with all stakeholders to find a pathway forward that both is sustainable and equitable for everyone. At its core, this bill is about keeping people connected to care, to support, to hope. And if done right, it will also save the state in the long run, as Representative Hicks has stated. So with that, Chair, I renew my motion to lay House File 2143 as amended over for possible inclusion in the future omnibus bill. And I also, as I always say, please make sure it's on top of the pile because this is important. Thank you.
Thank you. House File 2143 as amended is laid over.